Yeah. As we have started with our medicine module, yesterday the discussion was very important guidelines, that was sickle cell and thalassemia. So today we are continuing with management of inherited bleeding disorders in pregnancy. And this our today's webinar has been organized by MedHome. And so this is totally free webinar, and this is great initiative from MedHome Group to help all MRCOG aspirants. Okay. Now, today's discussion is very important guideline, which is management of inherited bleeding disorders in pregnancy. This guideline, actually, I will tell in brief my personal experience. When I prepared for my part 2, I was really, whenever I used to think to read this guideline, I used to say, no, let me leave it for some time. Let me leave it for some time. Again, because of this huge, it is very huge guideline. And sorry to say that, but not like very interesting that we will feel that, yes, very attractive and read it like that. So I used to postpone. One fine day, I sat with one of my very honest, my colleague and my friend and my MRCOG study buddy, and I read the whole guideline. Okay, that nightmare, I felt that it finished for me when I didn't find much of the material in my part 2 exam. But unfortunately, in my part 3, when I went for my OSCE, my second station was from this guideline, and that time my eyes opened as if, I don't know, I am where. And luckily, what I have read in my part 2, based on that information, I managed to do that station, and Alhamdulillah, I passed in first attempt. So this is the thing, that whatever important portion, what is included, and several times it was told in our presentation by Dr. Taqwa and by Aksa and all, Dr. Asia as well, that what is GTG's nice TOG articles, last 3 to 5, plus some of the important TOG articles and some BASH guidelines, BHIVA guidelines, some of science, Scottish guidelines and all, means not to take them lightly. MRCOG, as everyone says, that it is difficult exam, but it is not like it is not achievable. It can be achieved, but the key to success is hard work. That is the only key. And the thing is, you see, everyone, all of us, we know that when we do hard work, very important point, that whenever there is information, even in exam also, any question you want to answer, just think that on the same topic, if there is any GTG, same NICE and same TOG, whatever information you read only. If something is not there in GTG and if it is from NICE, so your second preference is NICE and third will be TOG. This is MRCOG exam. Whatever there in GTG, that is first important thing to answer in your answers. Now, second thing, whatever information is there, because same information when you find in 2-3 places, like GTG also is there, NICE is there, TOG is there also. So don't confuse yourself. What is there in GTG, don't mess up anywhere else for that information. Just keep that single information in your brain. Extra information, if you want to collect from NICE, from TOG, well and good, no problem for that. For particular topic, means suppose if this, whatever this hemophilia, von Willebrand disease, now what we are going to read now, information given here, don't confuse anywhere else. Keep it the same thing, because believe me, whatever question comes from GTG, it comes same, what is given, the percentage, or simple things like if you see, consider, offer. These is small points. When we sit in exam, under exam stress, we get confused with those points. Was it consider, was it offer? It should be given or can be considered. Two different meaning. Should be given means it is must. Can be offer means can be given, not can be. We can give, we cannot give also, like that. So these small points are very important when we read guideline. Any guideline, when you read it with exam point of view. Make your own question at each paragraph, at each highlight. Make question can come like this, so we can read. This will be the answer. Read in that way, so you will retain it. Okay then. So now time is short and guideline is very vast. So rather than wasting that time, let us start. Bismillahirrahmanirrahim again. So our Sorry. Today, our another day again with another chance. Okay. Yeah. So our today's topics, what we will cover in this guideline, one is our this complete inherited bleeding disorder where there is hemophilia, there is von Willebrand disease, then other small topics including this Glanzmann's thrombocythemia and Bernard-Soulier syndrome. There is supposed to be two TOG articles, which is iron deficiency and thrombocytopenia. But suppose if we are not, let us think, if we will not be able to finish it today, I promise you in my future lectures, these two TOG articles, this is my promise that I will update you about these two topics if we don't manage today. So, as Dr. Aksa mentioned yesterday, whenever in medical disorders, whatever syndrome, whatever disorder will come, we will start with preconception. Preconception, antenatal, intrapartum, postpartum, and baby. Always remember these 5 points. Any medical disorder you get, not only this, any medical disorder, preconception, antenatal, intrapartum, postpartum, and immediate care of baby. Suppose, let us think from nowhere one topic came which you don't have any idea, and it does happen in part 3. It happened in Viva when you are sitting for OSCE station and you don't have idea of topic, suddenly it comes. So if it is from maternal medicine, if you follow this protocol, this format of these 5 points, you can talk anything, at least you will get something to pass. Okay? What is hemophilia, what is its inheritance, and what is its types? In between, I have put certain slides to make it little lively. So it will be easy for all of us, including me, to go through this little bit dry topic. So what we are talking about today, hemophilia. Hemophilia is what? Bleeding disorder. So life is in blood. So anyone can tell me what is its inheritance?
X-linked.
Okay.
X-linked.
Great. That's great. X-linked what?
Associated with reduction of
X-linked recessive.
X-linked recessive. That is our complete answer. X-linked recessive disorder. Okay. Now here, what we know is what are this? Actually, this slide I found from our Stratog. So I felt just to put it, just for ourselves to make it little bit clear about inheritance. All of us, we know X-linked recessive disorder means it will be, suppose if female is a carrier, X-linked recessive means always females will be carrier, unless unfortunately, if the both male and female both. Hello? Please, whose mic is on, please put it off. Okay, so X-linked recessive means always females are carriers, and unless, unfortunately, if male and female partner both are carrying, then in that rare conditions, female also can be a disease. So here, let us think simple. X-linked recessive means female is a carrier. So what she will do? She will transmit to whom? To her daughter, to her son. So
To her son.
so son will be having the disease, daughter will become carrier because 2x is there, no? So 1x will go to daughter, and since it is recessive, so daughter will become carrier because another x she will get from father, which is normal. So one will be having the disease, son, and daughter will become carrier. So this is our X-linked recessive. Hopefully in our further lectures, we will come to brief part of genetics. So hemophilia A is factor 8 deficiency, B is factor 9. there is factor 11 as well. So let us, actually these all factors, all of us, we know that coagulation complete that intrinsic and extrinsic factor pathway. We will not go into detail of that here. Later on, if we have some time and all, anyone, as Dr. Aksa said, that someone will take the responsibility and share that cascade of all this coagulation pathway. So it will be better just for extra knowledge, extra information, if we have time. So it is, as we said, X factor 8, A, factor 9, B. Just another small, very small point. It is not necessary it happens, but sometimes that exam stress we understand only when we are in that examination hall and when that paper comes in front of our eyes. There also suddenly we feel that 8 was A or 9 was A. So just remember A and B sequence, so 8 and 9 sequence. Very sometimes this silly, not sometimes, this silly mistakes only happens there. Okay. So what is the hallmark of this disease is bleeding into joints and muscles. That we will not go into detail of that, because now we are going through here pregnancy related factors, what we are supposed to concentrate on. This is again I took from Strat Talk. I don't know how far it will be helpful, but nothing wrong in going through just this slide. Now there are two things. There is one more slide will come where there is factor level categorization of this hemophilia. This is percentage of factor. Another one will come where the factor level categorization based on factor level. So please don't get confused with these two slides. The another slide will come now. So what is mild, moderate, and severe? Mild when the factor percentage is 5 to 40%, moderate is 1 to 5%, and severe where there will be less than 1%. Now, another important, very small point to remember, in pregnancy, factor 8 level, it rises. But factor 9, it doesn't rise. This I have highlighted here because in further slides when the details will come, so we will understand that why we have highlighted this here. Now, what they have written, all these percentages again I have added in my last slide. I have compiled it together. So 1/3 of the females will be low factor level carriers. And these may have bleeding tendency, especially during the times of surgery and dental work. This is like historical, what we will ask them about the history. This will come in our preconception and antenatal part. During pregnancy, factor 8 level rises. This we said already. So they need factor replacement during labor and all. That we will see in our further slides. And another important point is this factor 8 level falls dramatically within 48 hours of delivery. So there is an increased risk of secondary postpartum hemorrhage. This point is important for this. And this point is again important in our von Willebrand disease also, because von Willebrand disease, which is associated with factor A's as well, together with that. So there is high risk of postpartum hemorrhage in those cases. Now, inheritance, how it should be assessed. Up to 50% of neonatal males with severe hemophilia have no previous family history. This is again important. Why? Because there is some percentage, and wherever percentage comes, this is statistics, exam point of view, it is important. Up to 50%. Somewhere it is given 30 to 40%, somewhere it is given 40 to 50, but in GTG, it is up to 50%. So stick to this point only. Up to 50% what? There is no previous family history. And in these cases, there is 90% chance that the mother is carrier with risk to next male child. So when this happens, then further all the genetic counseling and all, what all to be done, we'll see it further. Now, what are the different phenotypes and how is the severity be assessed? This I mentioned when I said previously, percentage wise, mild, moderate, and severe. Here, the actual amount of factor concentration. So mild is 0.06 to 0.4. Moderate is 0.01 to 0.5, and severe is less than 0.01. This is no other option other than by hearting these figures. And if we see further, when we go to treatment part, the lowest limit is 0.5 is there when we will go further. So these are the figures which you will make a small chart and put in front of your eyes in where you are reading, on your reading desk, fridge, refrigerator, in front of your dressing mirror, especially for females. So every now and then you will keep on seeing them. What are the risks to mother and baby? Now, maternal risk, what we are seeing, this is all we are talking about maternal medicine. So we are talking about pregnancy only. So whenever we do, there is any invasive procedure, if there is termination of pregnancy, spontaneous miscarriage, or at the time of delivery, all this is the time where there is heightened risk of bleeding. For baby, increased risk of bleeding, there's including intracranial hemorrhage and extracranial hemorrhage. These are the two things what all throughout our presentation we are going to stress on our management. Okay, now male baby with hemophilia are at increased risk of iatrogenic bleeding following delivery. So what is this iatrogenic bleeding? Anyone can tell me this?
Intracranial hemorrhage.
Yeah, no, what is the thing? Male babies, male only, no, mostly male only hemophilia. So they are at risk of iatrogenic bleeding following delivery.
Like instrumentation
Without
or
any
like
cause.
Excellent, excellent. Iatrogenic means what we do. Intervention, what we do intervention, we do fetal scalp blood sampling, we put electrodes, and what instrumentation delivery, instrument delivery and all what we do, that is iatrogenic. Iatrogenic means which is caused by us, it didn't happen by nature, that is iatrogenic. So again, I will repeat, and please, because there is quiz time also, we have a few slides. So maternal risk, start from the beginning, keep it systematic, so it will be easy for you people to remember how it is. Like, you are doing what, you are doing some invasive procedure to diagnose whether the baby is carrying or not, so there is risk of bleeding. You diagnosed baby is already diseased, want to terminate the pregnancy, so there is risk of termination. Without anything, spontaneous miscarriage happens, so risk of bleeding. And at the time of delivery, there is risk of bleeding. Then for baby, if you apply any scalp electrode, you do fetal scalp blood sampling, you do instrumentation, what level of instrument delivery, that we will see in our further slides. So what is the risk for baby is intracranial or extracranial hemorrhage. Oh, very fast quiz time came. I never expected that. So now, anyone, please, volunteers, what you talk now, let it be wrong. What you will talk at this time, you will never forget. So as we said, our female carriers of hemophilia in pregnancy are at increased risk of bleeding with
instrumentation,
With any invasive procedure, termination,
Invasive procedure,
excellent.
miscarriage, or at the time of
termination,
delivery.
time of delivery,
Excellent.
and at the time of delivery.
Excellent. Excellent. Invasive procedure, termination, miscarriage at the time of delivery. Okay. Now, male neonates with hemophilia are at increased risk of bleeding, including intracranial and extracranial hemorrhage. Yes or no? True
no,
or false?
Yes. True.
Yes. Yes. True. True. Then male neonates with hemophilia are at increased risk of iatrogenic bleeding following delivery.
Yes.
True.
True.
Yes, excellent. Risk of spontaneous miscarriage increased in hemophilia carriers. True or false?
True.
true,
This is the trick.
False.
This is
false.
Risk of
True or
hemorrhage,
false?
not the miscarriage.
False.
Risk of hemorrhage increases,
False.
not the
Excellent.
miscarriage.
Excellent. Very good. Risk of hemorrhage only increasing, but it is not increasing miscarriage rate. Excellent. Very good. So all of us are awake. And your answers are keeping me also awake. Huh? Okay, now what is, as we said, our format will be pre-pregnancy, antenatal, intrapartum, postpartum, and baby. 4 for mother, 1 for baby. So we came to our pre-pregnancy management. So what all things to be done in pre-pregnancy? Anyone, you can cheat. It is in front of you, slide. Okay. What we do whenever any maternal medicine condition comes, the thing is, first comes general health. Second comes, according to the condition wise, what health to be explained to the patient. Third thing, whatever the condition is there, according to that condition, her assessment. If the condition is genetically being carried away, so genetic counseling will be there, and multidisciplinary team. These points you include anywhere, wherever you find, just push them inside. So general health condition, then the whatever the condition, that condition wise, whatever the instructions we are supposed to give. Then if that condition is associated with some factors, with some disease, with the assessment of that condition. Then if it is genetically inherited, so genetic counseling, and any maternal medicine will include multidisciplinary team. So now here general health optimization, what they have given in GTG, they have given two things. One is correction of our iron deficiency, and second is attention to weight. Why correction of iron deficiency? Because this is not iron deficiency anemia, but
Risk of
they are more
hemorrhage.
liable to bleed. Excellent. They are at risk of hemorrhage. So we have to correct iron. And this obesity is risk factor for everything. So healthy lifestyle, attention to optimization of weight. So these two factors, if we understand and if we try to understand the thing, then it will not need it for us to buy hard. So since this is not like anemia, this is bleeding disorder, patient is very liable to bleed. So what we should see to correct her anemia, to optimize her weight. That is first thing. The second thing, now we are talking about certain condition. That certain condition is associated with what? Associated with some factor defect. So that factor has to be determined. That level has to be determined, whether she is mild, moderate, or severe deficiency. Finish. Now the third thing became that this is genetically carried away condition. So genetic counseling has to be done. Now genetic counseling, we are not the one to do. Definitely we will refer her to geneticists. But what all possible things can be told in genetic counseling? So again, to go with point of genetic counseling, how to start with, if anything can be done before pregnancy, that is one point. Second thing, yes, what can be done, then geneticist will explain, this is your condition, what is your partner's genetic categorization, together both, if he is very okay, nothing, only female partner, what is the condition, how it will be inherited. That is preconception counseling. Then once pregnancy starts, if something can be done, non-invasive, invasive. What is the gestational age? What are the risks and benefits of those testing? What is the further plan after doing the testing? Why we do the testing? Anything cannot be just simply do it and take it and sit it. No, there is some idea behind it. Why? If it comes that yes, it is male with a baby with severe hemophilia, whether the patient is planning to continue the pregnancy or no, she want to terminate the pregnancy, all these factors. So if we go step by step, first thing comes non-invasive, then invasive. In non-invasive, we have what? First is first is before the conception, that is pre-implantation genetic diagnosis. Okay, pre-conception. Once conception occurs, we have non-invasive and invasive. In non-invasive, all of us, we know this cell-free fetal DNA, which can be done from 9 weeks. After that, we come to chorionic villus sampling. We come to amniocentesis, and here additional factor we have, that is third trimester amniocentesis also. Why is that? That we will see in our further slides. In very few cases we find third trimester amniocentesis. For example, suppose if some viral infection and all, in those cases also, no, third trimester amniocentesis we see. So here also there is third trimester amniocentesis. For what it is there, we will see in our further slides. So before conception, that is pre-implantation. After conception, non-invasive, invasive. Non-invasive is cell-free fetal DNA. Invasive is chorionic villus sampling, amniocentesis, third trimester amniocentesis. Okay. Once we have done with this, now our next part is MDT. MDT, since this is hemophilia, so hemophilia clinical specialist. Then obstetrician has to be there, so obstetrician, and this is genetically inherited, so genetic counselor, plus all your midwife and all that blah blah will come. That is different, but these are three main MDTs here. this is the small details of what we said about our all this pre-implantation and cell-free fetal DNA, CVS and amniocentesis. This is the same I have copied from our GTG, so you can see it later on also. Just for your information, I have put it here. Nicely, they have given the details of all this. Now, important point here. Sorry. Important point here. This is interesting point also, and not necessary to know, but one additional information, and we don't know, suddenly may question may pop out, we don't know, so better to be ready with all these things. They have written NHS will commission 3 cycles of pre-implantation genetic diagnosis. So these 3 free cycles will be commissioned by NHS if couples at risk, those who are wishing to avoid the birth of an affected child. Okay, so this is one extra point I felt to be included here. So with all this information, now what I feel that all of you, including me, we have become now stronger, little bit stronger, because we, until now, we managed to grasp some idea of this huge guideline. We finished preconception. Now we will go to antepartum management. This is a little confusing part because here we have all this factor level, then treatment part. So overall, in all these 3, which mainly we are going to concentrate today, that is hemophilia A, B and von Willebrand. In all the 3, there are factor levels. There are situations when you will transfuse the factors, what factors you will transfuse. In all these things, tranexamic acid has very important role. Desmopressin is there with its some side effect, and this factor 8 and factor 9. So as we made some points in preconception, now we will do in antepartum also. What we will do, what we are supposed to do, we are supposed to monitor factor level, we are supposed to maintain it, and we are supposed to treat it. These 3 points. Is that looking okay, just to categorize like this for our memorization?
Yes, ma'am.
Okay, so we are supposed to monitor factor level. Once we monitor, we have to maintain it, and whenever it is needed, we have to treat it. So monitoring when to be done? At booking. At booking, before any antenatal procedure, as we have seen our previous slides, and in 3rd trimester. Okay, at booking, before any antenatal procedure and in 3rd trimester. Then we have to maintain it. Maintain what? At least 0.5 and 1 international unit if treatment is required. If you remember, in our previous slide, we were seeing mild, moderate and severe. So in mild, the factor level was 0.4 to 0.6. So average is 0.5. So factor should be maintained at least 0.5 international units. Should be maintained throughout. And if we needed to treat, means if the factor falls below 0.5, and if we are treating, we are giving the treatment, either we are giving tranexamic acid, either we are giving desmopressin, either we are giving factor itself. When we have to treat it, that time the level should be maintained at 1. So please be careful when you read question. This point is very important. What is the level? At what level it should be maintained? 0.5 international unit, and if needed to treat, it should be maintained at 1. So 0.5 and 1, 2 important figures. As we said earlier, factor 8 rises in pregnancy, but factor 9 tends to remain stable. Now we will see these points in detail. So what is antepartum management? Should be used with what now? As we said, factor level to be maintained at 0.5. If we needed to treat it, then at least it should be 1. Here, recombinant factor 8 should be used if level obtained with desmopressin are insufficient. Now you see what we have seen earlier. Again, sorry, let us make it simple. What they have given in guideline, that this, whenever we do any invasive procedure, what they have given, that this tranexamic acid, it should be considered in combination with treatment. Now we are maintaining part, factor level we said already. Now we are coming to treatment part. In treatment part, tranexamic acid has very important role, and it should be considered in combination with treatment for all those with level less than 5, means level went less than 5, and we are treating it. So that time, whatever treatment we will do, we will see that what we are giving the treatment, desmopressin, factor 8, factor 9. With all treatments, we are supposed to include tranexamic acid. That is when the factor goes less than 0.5. We are supposed to treat it. So when we are treating it, either with desmopressin, either with factor 8, or either with factor 9, together with that, we are supposed to give tranexamic acid when factor level goes less than 0.5, or when the factor is above 0.5, then the other treatment is not needed. Desmopressin, factor 8, factor 9 is not needed. That time we can give tranexamic acid as a sole therapy. Is it clear?
Yes, ma'am.
Okay, if you want, I will repeat again, because this is little bit confusing thing, and again we have to revise it. What is our aim when we are doing any invasive procedure, any surgery or anything? That time, to maintain factor at least 0.5. That is our aim. Okay, so to maintain factor, we are supposed to treat it. This treatment requires what? This treatment is either desmopressin, factor 8, or factor 9. So all above these three, the important is tranexamic acid, which is available with cyclocapron name. So this has to be included in all the treatment thing, either with desmopressin, with factor 8 or factor 9, as long as we are treating to correct the factor, to bring it above 0.5. But suppose if the factor is already above 0.5 and above, if the factor is already high, in that case, only tranexamic acid should be given as a sole therapy. It is indicated. And it should be continued until bleeding settles.
चेक कराती है ना, तो फीस नहीं मैं उससे देती, तो मेरे लिए सूट लेके आई और ये हैंड सैनिटाइजर मेडिकल.
Please off your mic. Please mute your mic, my dear. So this is our treatment part. Second treatment thing is, whenever the factor is low, now when we are treating, we talked about tranexamic acid. This is the sole therapy in everything what we are including. So to correct the factor, what we are giving desmopressin. Desmopressin to raise what? Factor 8 level. When we are treating factor 8, we are giving desmopressin to treat factor 8. If it goes below 0.5, when we are doing any surgical procedure or any invasive procedure. Okay. Now, what is the important factor with desmopressin? It is there. Further slide is there, especially on desmopressin, since it is antidiuretic. So, whenever we are giving antidiuretic, what factors to be considered? If the patient is hypertensive, if any cardiac problem, if any arterial problem, like that, that is one thing. And fluid to be restricted, 1 liter for 24 hours. This, all the details are there, but this here I have just shortlisting it. Fluid to be restricted, and if not possible to restrict the fluid, means patient is dehydrated or something like that, in that case, we are supposed to monitor electrolytes. So these three things with desmopressin, it is there further in our slide, no need to by heart now. So we are treating here factor 8. Initially we are treating with what? We are treating with desmopressin. When we are treating, either we are doing any invasive procedure, any surgeries or anything, what factor level we are treating? If it goes less than 0.5, If the factor level is already above 0.5, so not this treatment is needed, but that time tranexamic acid sole therapy should be given. Okay, this is our treatment of factor 8. Now we gave desmopressin, but it is insufficient and factor is not recovering. That time we are supposed to give factor 8. Factor 8. If levels obtained with desmopressin are insufficient, or maybe the condition is not responding to desmopressin. Now we are coming to factor 9. What is it? Factor 9, it will require to cover invasive procedure, as we said earlier already, if level goes less than 0.5. Because for factor 9, usually they don't respond to desmopressin. So factor 8, it responds to desmopressin. If it did not responded or the level obtained is not sufficient, then to go for factor 8. But in factor 9, they don't respond to desmopressin. So directly factor 9 treatment will be needed. Clear so far? I'm sorry, this is confusing.
Yes, ma'am.
And difficult to
Very
digest, but
clear.
I am trying my best to make it as simple as possible.
Thank you.
Yeah, madam, no problem.
Okay, so here what we talked there, I have prepared this slide. This is just for your last minute revision, this slide. The details of this slide is here. What we said now, like factor 8 to obtain level, which we said 0.5, to be treated with desmopressin. If we did not find sufficient level, then to treat with factor 8. Factor 9 is required to cover surgical or invasive procedure in women, factor less than 0.5. 0.5 and 1 is now, it should become our dream factors now, should be there, these figures. Now, whenever we are giving treatment to raise clotting factor levels, it is important to monitor. Now, when we are giving something, to just not to leave like that, we have to monitor the response of the treatment by measuring what? Again, to measure plasma clotting factor concentration, and this should be 4 to 6 hours following treatment to facilitate whether the dose to increase or to decrease. All these details, I don't think this all will be needed. I have just added it, if you can give one glimpse to it like that. Then following any invasive or surgical procedure, a plan for ongoing treatment is required to maintain the coagulation factor in normal range for a suitable duration determined by the nature of procedure. Means up to certain limit has to be followed, that coagulation factor. Then a clear plan for intrapartum care of a carrier and baby should be available in advance of 37 weeks of gestation. This can come as a SBA, this can come as a EMQ and all. So just I have highlighted it. Women should be, another important point is women should be seen in anesthetic clinic and please mute your mic, my dear. I'm sorry. Then women should be seen in anesthesia clinic and neonatologist should be informed of the intended delivery of a baby with hemophilia. So what will be our plan now? Whatever factor we corrected, everything we did. Now supposed to be clear plan should be there. In what should be included in that plan? That plan in advance, in advance of 37 weeks of gestation, patient should have pre-anesthesia consultation and neonatologist to be involved. So as we said our MDT earlier, these are again the part of MDT. Neonatologist should be aware that there is a baby of hemophilia possibility going to be delivered. Then now this point, if antenatal diagnosis has not been performed in male fetuses, then should be managed as if the baby is affected. Where else this point is, we have read earlier also somewhere, this point. If antenatal diagnosis is not performed, then should be considered as if the baby is affected. A simple point, if you remember HIV guideline. Now in UK, everywhere now, not only in UK, if the patient is not agreeing, you cannot force her for HIV testing. So if HIV testing is not done until and if patient refuses, she will be considered as if affected and you will manage case like that. Isn't it? So here also, if you haven't done the diagnosis, any pre-genetic testing, nothing is done, in that case, baby will be considered as if the baby is affected. Then external cephalic version should be avoided in affected or potentially affected male fetuses and female fetuses who are obligate or possible carrier of severe hemophilia B. Why have they have said especially this point? This we will see further. Now, we manage preconception, we manage antenatal. Now we came to mode of delivery. One more thing I will tell you, while preparing this presentation, I have made one word, this thing also of like little bit what we have presented here, the points, some extra detail points also. Like you see, whenever the guideline is there, there is some highlighted point, there is some small points also in between. This small writing is also very problematic, my dear. Question comes from there also. For me, in my part 2 exam, cholestasis, I am not remembering where I have read that figure. I'm not remembering, but I'm remembering somewhere I have seen. Finally, I found there in small writing. So that small writing should not be missed also. So from this small writing, whatever important points I have collected in one word format, and later on I will post it in our group, or I will request Dr. Hira to post it. So now we came to delivery. Patient was pregnant. We did preconception thing. She got pregnant. We managed her antenatally. She reached up to the delivery. So what will be our plan of delivery now? What is there? Planned cesarean in affected male babies, especially those with severe hemophilia, or if the fetal status is unknown. Okay? This is not like recommendation, but it can be considered. Planned cesarean section. First of all, before we go to anything, very important thing is multidisciplinary decision. The decision of delivery will be taken by multidisciplinary team. And another thing, there in UK and all, these hemophilia carriers with those who are with high risk and moderate and severe things, severe factor deficiency, they are delivered in hemophilia specialized hospital, their centers only. It will come further in our slides. So MDT decision about that mode of delivery, cesarean section in view of affected male babies, especially those with severe, or if the status is unknown. If the status is unknown, you don't know whether the baby is severely affected, moderately affected, or what. So this is the option. Then if we plan elective cesarean section, it should be 39 completed weeks with clear plan written for event of spontaneous labor. Suppose if patient presents before spontaneous labor, which happens in 10% of the, how many percent? There is in VBAC some percentage is there. I believe it is 10%. We will see that in VBAC guidelines. So clear plan has to be there. Then suppose we are giving trial of vaginal delivery, there is no indication for induction of labor, only it is for obstetrical reason. Why? Because the more spontaneous labor, more natural progress, minimal chances of intervention. But planned induction will become necessary where suppose if the patient is supposed to deliver, please someone off your mic, please. So planned induction where it will be necessary because patient is supposed to deliver in a specialized center, and if she lives far away from a specialized center and all, so that time it can be risky for her and for baby. So in those cases, induction of labor will be considered in those cases. So here 3 important points: planned cesarean section at 30 MDT decision of the delivery. Planned cesarean section can be offered in those with severe or unknown status. If cesarean section we plan, it should be 39 completed weeks. There should be clear plan of labor if it starts earlier. Spontaneous labor, no indication of induction of labor unless any obstetric associated factor. And plan induction where if there is any social issues like patient lives far away from the center, to minimize any possible risk to mother and baby. Now, up to here, we have seen mother. Now we are going to baby. So this image I found there in
Ma'am, I have a
strata.
question.
Yeah, please.
Ma'am, in severe, you said in severe hemophilia is according to percentages or?
According to percentages. Yeah. According to percentage, what we will do during our antenatal period. That is our first point to assess the factor level.
Okay.
In our antenatal slide, that was our first factor. So here, management of labor. Thank you, my dear. Management of labor. Sorry, whoever has whatever doubts in between, please, in between, you can ask any question. That is one thing. And second thing, all of my near and dear, they tell me that my speed, it becomes very fast when I talk. So if you people find like that, please slow me down in between. Huh? You can feel free to say that. Now, what are the fetal concerns? We have seen in our earlier slide also. Again, we will revise it. What we should avoid ventouse and mid-cavity forceps. We know that because ventouse, because of intracranial, extracranial hemorrhage, and mid-cavity because maybe some manipulation is needed. Now here, outlet forceps we can do when we evaluate the risk and benefit to do cesarean at this stage, because that stage cesarean also it is risky for mother. So outlet forceps, that's why they have specified mid-cavity forceps. Fetal blood sampling we said already, scalp electrode we said already. Now, plan for intrapartum management and second stage of labor involving senior obstetrician should be documented. This we know already that this is MDT. Patient will be delivering in hemophilia specialized center, and hemophilia specialist plus senior obstetrician will be around or will be dealing with the situation. So here for the baby, this is for mother. Now for female fetus, there is no evidence to recommend any special measure. So here also bias with females, even GTG also. In babies potentially affected with mild hemophilia. Now this is another important point which can pop out as the SBA or even our EMQ also. What is that? Mild hemophilia, potentially affected with mild hemophilia. Judicious use of FBS or fetal scalp electrode can be considered in order to facilitate vaginal delivery and avoid morbidity. But senior involvement. Why this point is important here? Because you see, we are dealing with what? Mother also at risk. Baby is also... Hello? Hello? Anything there? Anyone was asking anything?
Continue, please.
Yeah. Okay. So
No,
here... Okay, thank you. What we are dealing here, mother also is at risk. Like it is not very safe also to take her and to cut her just to do cesarean section. So whatever the possible factor where we can avoid possibility of cesarean section. So what they have given, if there is mild hemophilia, that time if needed last minute FBS, in that case, it can be done to facilitate vaginal delivery, but senior obstetrician involvement. So suppose if the situation comes that baby like potentially affected with mild hemophilia and CTG suspicious, that also our guideline we will see in Dr. Asia has beautifully presented that CTG things on a group I have seen. So in that case, FBS can be considered, but with senior involvement. So this again possible point to remember with our exam point of view. Then female fetus who is at risk of carrying severe hemophilia may theoretically be more at risk of intracranial and extracranial, and this should be considered in birth plan. Okay. Now, if the female fetus is there and if she's carrying severe hemophilia B, as we said in rare cases, here still she's carrier. Rare cases, female also can be diseased, where very, very rare, where father and mother both, like father is diseased already and mother is carrier. In that case, female can become a disease also. These are very rare cases. But here, if she's a carrier, so if here she is a severe carrier of severe hemophilia, in that case, again, birth plan has to be modified according to our diagnosis. Now we came very important factor of this intrapartum care, which is analgesia. Analgesia, what we are saying here are okay. What factor level is required for the insertion and removal of epidural catheter and for spinal anesthesia?
0.5 international unit per ml.
Per ml.
Excellent.
Above 0.5. Above 0.5.
Above 0.5. Excellent. You see, this above and at. Please off your mic. So, these small points are very important, because as I said, in that exam stress, there, and believe me, they give like these options very nearby. They will give factor level is 0.5. Factor level is above 0.5, factor level is below 0.5, and that time we get confused that what we have read. We have read 0.5 or above 0.5. So this above 0.5. Then intramuscular injection should generally be avoided. True or false?
True.
Why?
Risk of hemorrhage, the bruise, hematoma.
Hematoma. Excellent. Hematoma formation. So here is our discussion now. Senior anesthetist, as we said already, our MDT, clear plan for analgesia and anesthesia should be available in maternal records. So what all plan we are recording? We are recording birth plan, and this plan should be there before 37 weeks. We are recording her mode of delivery plan, and we are recording her if she presents before planned cesarean section. We are recording anesthesia plan. All this plan should be there. Then a factor 8-9 level of more than 0.5 are required for insertion and removal of epidural catheter. Intramuscular generally should be avoided if factor levels are less than 0.5. So this is the same, all analgesia is same, level is 0.5. Most of the factors level is 0.5, only somewhere little different, which we are not going to stress out with that. Generally to remember 0.5. Now, what is hemostatic management during labor? Again, now, antenatally we managed. If we did any invasive procedure, any termination, anything, we manage that. Now, patient is in labor, and how we are going to manage? Because there is possibility of bleeding. So how we are going to manage it? If clotting factor levels are less than 0.5, again, same factor level, desmopressin should be given to raise factor 8, or factor 9 concentrate should be given to raise factor 9. And our aim is what? As we said earlier, that factor level should be maintained above 0.5. But if we are treating it, if it went less than 0.5 and we are treating it, after treatment, level should be maintained to 1 international unit per ml. So for factor 8, we are giving desmopressin. For factor 9, we are giving factor 9 concentrate.
हैदर आपने क्या झाड़ा है यार? एक काम बंदा
Then,
आपको कहते हैं आप वो भी नहीं पूरा करते.
नहीं करेंगे next time, don't worry. Please put off your mic. Mute your mic, please. Okay, now, as we said earlier, if we remember, in our treatment plan, tranexamic acid was the first name. Why? Because it could be considered as a sole therapy for women with low normal levels of factors in conjunction with desmopressin. Okay? With to increase the factor 8 or with factor 9. Means in both the condition, factor 8, factor 9, hemophilia A, hemophilia B, in both the condition, we are giving tranexamic acid. If we are treating them with factors, once the level goes below 0.5, that time should be combined with tranexamic acid. If the level is above 0.5, tranexamic acid can be given as a sole therapy. So it is there in both factor 8, factor 9, hemophilia A, hemophilia B. Desmopressin we are giving in factor 8. We are not giving in factor 9. To correct factor 9, we are giving directly factor 9. Okay? And now here when we will start the treatment, when to be given the treatment, it should be close to delivery. Close to delivery. This is a small point, but this can be as a SBA. I don't know, maybe. So just to remember, treatment at what time to be given. We cannot give like very early labor and this and that. So it should be close to delivery in active labor, supposed to be. Okay. Now is our clear. Am I clear so far here?
Yes, ma'am.
Okay. Thank you, dear. Now we reach to postpartum. postpartum. Now, as the patient is at risk of bleeding, so what is the most important thing to minimize the risk of bleeding? Patient delivered already. Baby delivered already. Placenta is not yet delivered.
Active management of third stage labor.
Excellent. Thank you very much. Active management of third stage of labor. Now, sorry, just away from this guideline, anyone can tell me what is the active management of third stage of labor? What is nice recommendation about active management of third stage of labor?
Control contraction.
Okay.
After
5
the delivery.
international unit.
Cord clamping within 1 minute.
Hmm.
Oxytocin 10 units intramuscular.
5 units intramuscular.
How much? How much oxytocin?
10 units intramuscular.
Okay.
5 units.
Normal delivery and 5
Delivery.
unit with
5 units IV for cesarean section.
In active management of third stage of the labor, there should be 10 unit intramuscular oxytocin after the delivery of the baby on the anterior lateral compartment of the leg, thigh, and control cord traction and early cord clamping.
Thank you. Both the figures are there. 10 units also there, 5 also there. IM also there, IV also there. 10 units intramuscular normal delivery, 5 units intravenous during cesarean section. So good. Means we are awake, including me. Now, so we did active management of third stage of labor. Patient delivered already. Antenatally we managed. Intrapartum we managed factor 8, factor 9. We manage level above 0.5. Again and again I'm repeating this sentence. Why? For ourselves to grasp it. We managed above 0.5. If factor went below 0.5, we treated. What we treated? We treated factor 8 with desmopressin. We treated factor 9 with factor 9 concentrate itself. But in both the condition, tranexamic acid was there with both the factors together. But if the level was above 0.5, tranexamic acid will be given as a sole therapy. Now patient delivered. To minimize the chances of bleeding, we manage actively third stage of labor. Then we have to manage again these factors because we cannot just leave. Why? As we said in our earlier slide, that within 48 hours, factor 8 falls dramatically. So very high risk of postpartum hemorrhage. So we have to again maintain level above 0.5. Above 0.5. Now again, this is your possible SBA or EMQ, whatever it will come. So for how long we have to maintain this level 0.5? 3 days following uncomplicated vaginal delivery and 5 days following cesarean or instrumental delivery. This point is very, very important. You see, in GTG or in any guideline, whatever point they have given, behind every point, there is some reason. So we have to understand it very clearly, not to confuse ourselves. If it is written 3 days following uncomplicated vaginal delivery, uncomplicated, this factor is very important. Suppose if patient landed up with postpartum hemorrhage, suppose if she landed up with extended tear and it was sutured under GA, that will not remain uncomplicated delivery, means our monitoring will go beyond 3 days. So exam point of view, to remember 3 days uncomplicated delivery, 5 days cesarean or instrumental. Okay. Then again, now another important point, this tranexamic acid is again playing important role here also. Initially it played very important role. It was everywhere, above 0.5, less than 0.5, postpartum also. It will be continued until lochia is normal. Okay, anyone can tell me what is the dose of tranexamic acid will be given in this condition?
1 gram 6 hourly or 4 hourly.
Either 6 or 4.
4 to 6 hourly.
4 to 6 hourly according to the patient's condition.
Yeah.
It is 4 to 6 hours or it is 3 to 4 times per day. This will be homework for tomorrow, to be posted in the group. Because either we will remember how many times per day to be given, or we will remember how frequently it will be given, 6 hours or 4 hours. Okay, so this is homework. Someone will find out and post it in group. Because what we will, someone please put off your mic. So what we will read the point now, this we will not forget. So how frequently to be given this tranexamic acid, this is homework. Then another very now you see, for any postpartum patient, there is mother, there is baby. Points to remember systematically so that we will not forget. Once the patient is delivering, we will see active management of third stage of labor, bleeding controlled, not controlled, that we managed already. After that, whether she need antibiotic. Whether, this is again another form. This is again the format of maternal medicine. Then the patient bleeding point we considered, whether she need antibiotic, whether she need thromboprophylaxis, breastfeeding. And this is generally I'm telling for maternal medicine module, if the patient was on any medication, whether that medication she will be continued, and is it safe in breastfeeding or not. These are important points. Systematically go means you delivered the patient, there is bleeding, so you have to manage bleeding. That is one point. Whenever there is bleeding, chances of infection. So antibiotic needed, not needed. Generally I'm talking. Whenever there is bleeding, chances of thrombosis. So thromboprophylaxis has to be considered. Patient delivered baby is there, breastfeeding. Was patient on any medication? So that medication to be continued, not to be continued, or is it safe or not for breastfeeding point of view. So these points again with maternal medicine module after the delivery in postpartum management. 5 points. If anybody remember more than that point, please write it in the group. So thromboprophylaxis should generally be avoided where factor level is 0.6 or less. Here now we are seeing one new figure. Till now we were seeing 0.5 and 1, above 0.5 and 1. Now here we found 0.6. So here thromboprophylaxis should generally be avoided where factor level is 0.6 or less, but will need to be considered in women with thrombotic risk factors. So here careful balance has to be done, and definitely this is again MDT. They don't want us to treat everything. When we go for part 2, part 3 exam, our knowledge is not consultant level. We are not still yet consultant. We are at the level of ST5 only. So to have the idea, we are not to go to manage it, like if patient with thrombosis or something like that. But thromboprophylaxis idea we are supposed to have. And in this case, suppose if patient, practically if we are managing the patient, definitely we will involve hematologist only. But for our knowledge, to be considered if women is with high thrombotic risk factors, again balancing her risk and benefit for her own case. Then when the patient will be discharged, hemophilia center should maintain contact with the patient. This is again after discharging, because she is at risk for postpartum hemorrhage. For her factor, if it goes down, because there are chances factor may, as we said, factor 8 may go down and after the delivery. So in that case, hemophilia center should be in contact. Again, we will see in our von Willebrand disease, it is more chances of secondary postpartum hemorrhage there. Okay. Again, one more, which is other case. Generally, I'm just asking in between question just for some change. What is the other cases where we do the notification in center and those center follow the cases? Which is other condition?
Gestational trophoblastic diseases.
Excellent. Gestational thromboplastic. Excellent. Very nice. Now we manage mother. Now we came to baby. So at delivery time, what vitamin K is given, so that should be given oral. We know that intramuscular injections we are not giving to mother, so definitely we will not give to baby. Now whatever we did based on mother's severity of condition, or based on whatever pre-genetic and genetic testing, whatever we tested for the baby, now we are going to do the diagnosis on baby, himself or herself, whatever. So in that case, oral vitamin K, cord blood sampling, cranial ultrasound to be considered, then cranial MRI should be undertaken in neonates with symptoms or signs suggestive of intracranial hemorrhage, even though ultrasound is normal. This is very, very important point. Like, we did ultrasound came normal, but there are signs of intracranial hemorrhage, what we are seeing. In that case, we are supposed to do MRI. Okay? Where is the other? There is one more condition where even though it comes normal, still we what is that? Thromboembolism. Thromboembolism, if you people remember. Unfortunately, that lecture was supposed to happen in previous weeks, but I was the one supposed to present it. Unfortunately, due to some unforeseen circumstances, I could not do it. I will do it in future, inshallah. So, oral vitamin K, cord blood sampling, cranial ultrasound. We did cranial ultrasound. It came normal, but baby is symptomatic. Signs and symptoms are suggestive of intracranial hemorrhage. In that case, cranial MRI has to be undertaken. And then baby also will follow up at hemophilia center with mother. Okay? This 5 points in baby. We gave vitamin K, we tested baby, we did ultrasound, is still symptomatic, we did MRI, and we arranged follow-up at hemophilia center after the discharge. Now, cord blood sampling and diagnosis testing of female babies born to mothers who are carrier of hemophilia is a big bias, again, not recommended. Thank you. Okay, another dilemma now. This von Willebrand disease. Okay. Okay, my dearies. So, again here, this is what is the classification and inheritance. This is, I took this part from Stratog only. What I found there, I thought maybe it will be helpful. Let us see what is that. Inherited bleeding disorder. I remember yesterday Dr. Taqwa said something about sickle cell. Anyone remember that? Commonly inherited disorder. Excellent. Very good. So, this is von Willebrand is the most common inherited bleeding disorder. Okay? So, don't confuse with that, because if very good point, what Dr. Taqwa told yesterday, and you remember also, excellent that is, but that is commonly inherited condition. This is commonly inherited bleeding disorder. Okay, now it affects up to 1% of population. It is caused by faulty gene on chromosome 12 and all. This is no need to remember this figure, I believe. I hope they will not go up to that level to ask this. Von Willebrand factor is a plasma protein that has two main functions. What to do? Here is the role. Why we said in our earlier slide that factor 8 will have some role here in von Willebrand also, because von Willebrand factor, it stabilizes factor 8. And it helps in adherence of platelets to injured vessels walls, means to control the bleeding. Now, what is the classification? This is my nightmare. As I said, I sat on my second station, and in front of me, whoever role player was there, she is telling that I am 20 weeks pregnant. I was not aware of it, that I am pregnant. Suddenly she found herself pregnant at 20 weeks. And she is a case of this von Willebrand disease. I felt for a while, for a few seconds, I was like in shock. Like, where am I? But I had to come out to that shock to answer there, because in my brain, that time, that next again, in second attempt, I don't want to come and sit on that chair again. And for all of you, I hope all of you are thinking like that only, that you don't want to go back again to that hall. So hopefully, inshallah, first time only, Allah bless all of you with God's grace to come out of this because MRCOG for Asian people, especially when we don't work there, when our practice is not like that, so it looks like it is something which is really difficult. But believe me, it is not. It is not. With practice, with our self-confidence, and with hard work, it is really achievable. But I will not mention easily because it needs our dedicated efforts. So we have type 1, 2, and 3. Details, I don't know how far you will remember, but I have put it here. Quantitative deficiency, 75% of the cases. Type 2, I don't know all the details. Type, and type 3 associated with negligible amount of 1 milligram. So this is the severe one, type 3. Here again, same, quantitative, abnormal, and undetectable. Same, both from our strat talk I have taken. Now, what are the risks in pregnancy to mother and to baby? So here there is possibility of hemorrhage. What is the hemorrhage? Antepartum hemorrhage, primary and secondary postpartum hemorrhage. This is the most risk factor of this von Willebrand disease. Then all women should receive counseling about risk of increased bleeding, especially women with type 1 whose von Willebrand level does not rise above 0.5, means again factor is same, and type 2 and 3. As we said, the type 3 is the severe one, but in type 1, where the level does not rise about 0.5, and type 2 and 3. So all they are at increased risk of bleeding. Now, what is the pre-pregnancy and antenatal management? So again, as our format for all maternal medicine module, MDT approach. In MDT, who all will be there? Hemophilia team, lab staff, obstetrician, midwives, anesthetists, neonatologists. This is our MDT team for this condition. Then bleeding phenotype should be assessed, as we did there also. We assessed factor level no, in our hemophilia. So here bleeding phenotype will be assessed. Then historical diagnosis, like whether her menses, she's like heavily bleeding, whether there was any what do we call bleeding after dental extraction and all those type of historical things. Then if she was already, if she is on treatment and all, if she is taking the treatment, what is her response to desmopressin? This we will see now further slides, the treatment part, and von Willebrand factor and factor 8 level to be checked, because as we said, von Willebrand stabilizes factor 8. It helps factor 8. So factor 8 also has to be checked with von Willebrand factor. When we will check at booking, in prior to any procedure, and in third trimester, same as hemophilia. It is the same. Okay. Then now the delivery. Type 1 who achieve normal factor level. What is normal factor level? Above 0.5 international units per ml. They will be managed in standard obstetric units. But women with type 2 and 3 and with severe type 1. What is severe type 1? Less than 0.5 international units per ml. They will be managed in hemophilia center. Clear so far?
Yes, ma'am.
Yes, ma'am.
Okay. Okay. Now, what I have shortlisted here, this is the same slide only. This, like for your last minute revision, hopefully it will be helpful. So we said aim for factor 8 and von Willebrand factor activity level of 0.5 or above to cover surgical procedure, spontaneous miscarriage, where invasive procedures are required. If von Willebrand factor activity or factor 8 levels are less than 0.5, women should receive hemostatic support in the form of desmopressin, where responsive, or von Willebrand factor concentrate. You see, sorry, why I went so fast. This is the same as factor 8. What we treat, factor 8, we treat with desmopressin. Factor 9, we don't treat with desmopressin, no, because it doesn't respond. So, von Willebrand factor, it stabilizes factor 8. So, treatment is same, desmopressin. Okay? And where it doesn't respond, there we treat with von Willebrand factor concentrate. Then, treatment should be with desmopressin in preference to blood-derived factor concentrate where possible. This is safe for use in pregnancy and at delivery, but should be avoided in preeclampsia. We said about desmopressin, since it is antidiuretic, so it should be avoided in conditions where the blood pressure will get affected, no? So it should be avoided in preeclampsia. Then, as we said, the fluid should be restricted 1 liter for 24 hours. If the situation is like that where we cannot restrict the fluid, there we should do electrolyte management. Why we will do this? What is the problem with why we will do electrolyte monitoring? Why to be done? What can happen? Anyone please? When there will be fluid overload, what can happen?
Cerebral edema.
Hypernatremia and hypokalemia.
Hyponatremia. And what hyponatremia can cause? It can
Cerebral
cause
edema.
fits also, yeah, cerebral edema and fits. So fluid intake, we said already, hyponatremia. Patient with type 2B von Willebrand may develop thrombocytopenia following desmopressin. This is important. Sorry, I could not highlight it. Maybe it missed. This is important. It can be SBA or question because desmopressin is not indicated in this type of von Willebrand disease. Type 2B. Type 2B. See now, again, just to make it simple, just remember what we said. Our hemophilia A is factor 8. Hemophilia B is factor 9. In factor 8, we do give desmopressin. But in factor 9, which is hemophilia B, we don't give desmopressin, isn't it?
Yes, ma'am.
Yeah.
Yes, ma'am.
So just to make it simple for ourselves, for ourselves to make it simple, just remember in type 2B von Willebrand, like hemophilia B, no desmopressin. Type 2B von Willebrand, no desmopressin. Why? Because patient can develop thrombocytopenia. Because we have to find some equation to memorize this, all these things. Okay. Where plasma products have already been used in past. Okay. Now, this is again, as Dr. Taqwa said yesterday, whenever like patient is receiving any blood or blood products, what we are supposed to do, yesterday it was said that antibody screening, then viral blood transfusion transmitted infection screening, vaccination, isn't it? So the same thing here. If the patient is already has been receiving the plasma products, in that case, screening for transfusion transmitted infection. This we didn't said in hemophilia. We did not said that, no? In hemophilia, this part was not there. Isn't it? This part was not there in hemophilia, but here this part is there. So in this case, screening for transfusion transmitted infections, vaccination to be done if it was not done already for hepatitis A and B, and whenever we are giving any blood derived or plasma derived concentrates, there should be, or any blood consent has to be there, no? So this is additional part here which was not there in hemophilia. Clear so far? Any doubts till here?
No, ma'am.
I know there will be many doubts because this guideline is like that. Whenever you guys remember to ask anything, later on also you can write in chat and where our group, and we will answer there, no problem. Because this is not easy task also in one go to get along with this huge guideline and this information, because this is not in our daily day-to-day practice. Now, as we earlier so many times we said about this desmopressin, now let us see what is desmopressin. Desmopressin is generally safe in pregnancy and at delivery at a dose of 0.3 microgram per kilogram of pregnancy body weight. It is administered intravenously or subcutaneously. I believe there are some nasal sprays as well of desmopressin. Then I don't know how far the dose is important, but I have written here 0.3 microgram per kg. Then it increases the level, it increases the von Willebrand factor level by 3 to 5 fold, which normalizes von Willebrand factor and factor 8, we know that. And in most cases of type 1 and some subcategorize of type 2. Why it is mentioned here, some subcategorize of type 2? Because we saw just now type 2B. Type 2B, desmopressin cannot be given because it causes thrombocytopenia. Hemophilia B, factor 9, doesn't respond to desmopressin. Type 2B von Willebrand, we don't give desmopressin because it causes thrombocytopenia. Okay, now where all it is not recommended, it is not recommended type 2B because of transient thrombocytopenia. Type 3 von Willebrand patient, as they lack release stores of von Willebrand and do not respond to desmopressin. It is not contraindicated, but if you give also means mafi faida, give, only we are overloading them. Then patients who are intolerant or those who are adverse effects, preeclampsia, any arterial disease or uncontrolled hypertension, all these are contraindication for desmopressin. These points are easy to remember because it is antidiuretic. Antidiuretic will retain water. Water retention it is contraindicated where any arterial disease, any cardiac problem, any uncontrolled hypertension, preeclampsia. Simple. Then if they are intolerant, if adverse effect, definitely we will not give. And type 2B, thrombocytopenia, we will not give. Hemophilia B, factor 9, doesn't respond, so we will not give. Okay, now we reach to intrapartum. We finished antenatal, now we are coming to intrapartum. The mode of delivery should be guided by obstetric indication. Again, obstetric indication means here not any indication for cesarean section, but we will see what they have written further. For fetuses at risk of having type 2 or 3 von Willebrand, fetal blood sampling, external cephalic version, fetal scalp monitoring, ventouse delivery, and mid cavity forceps should be avoided. So same as we said in hemophilia. Okay, timing of treatment should be as near to delivery as possible, and pre and post treatment levels of von Willebrand activity and factor 8 levels should be measured and repeated after delivery or if labor is prolonged. Same as we said there. Tranexamic acid should be considered in combination with treatment for all those with von Willebrand activity less than 0.5 or as a sole therapy for those with levels above 0.5 if clinically indicated. This can be given either intravenously or orally as well and can be started prior to delivery. So same again there, what we said. Can be given with factor when level goes less than 0.5. When it is above 0.5, it can be given as a sole therapy. Platelet transfusion as well as von Willebrand factor replacement may sometimes be required in type 2B. Type 2B, why only platelet? Because as we said, there is possibility of thrombocytopenia in that. So they may need factor replacement. Then, thank you, Shahid. Then neonates with type 2 and type 3 and more severe forms of type 1. When we said more severe forms of type 1, when the factor level is less than 0.5, will have reduced level of von Willebrand factor with or without factor 8 and maybe at increased risk of both. Again, same, intracranial or extracranial hemorrhage. So here, how can analgesia and anesthesia be safely managed? More or less same points, pre-anesthesia evaluation. Type 1 von Willebrand, where von Willebrand factor activity has been normalized. Normalized means above 0.5. Central neuraxial anesthesia can be offered. For patients with type 2, central neuraxial anesthesia should be avoided unless level is more than 0.5. Then it should not be given in cases of type 3. So here, 3 different information, but the outcome of all these 3 information goes again to factor level only. Type 1, it can be offered if the factor level has been normalized. Normalized is what? Above 0.5. In type 2, should be avoided unless level is more than 0.5. Type 3 should not be given. Why they are that much stressing on this central neuroaxial anesthesia? Because again, if we go for GA, it has its risk factor for mother. So in that way, all the whatever parameter we can find that we can give them this central neuroaxial anesthesia. So all these points has been written here. Type 1, if the level has been normalized, can be offered. Type 2, aslan it should be avoided, but if the factor is more than 0.5 can be given. Third thing, in type 3 there is no factor, nothing, should not be given only in type 3. Now repeat treatment prior to epidural catheter removal. Now here when we are giving the doses, whatever we are giving, desmopressin or factor level, whatever we are giving, it should be given while before the insertion, but before removal also. Prior to removal also, factor has to be replaced. Intramuscular injections and postnatal non-steroidal NSAIDs are only suitable in short term, where again the factor level is more than 0.5. Only once until now we have seen level 0.6. Where did we see that? In what context it was there?
It was in postpartum
prophylaxis. Thank you very much. Excellent. Otherwise, it is everywhere above 0.5 and 1. So what is postpartum management now? Postpartum, again, factor level more than 0.5 for at least, as we said earlier, 3 days, again, uncomplicated vaginal delivery, and 5 days following cesarean section or instrumental delivery. Then consider tranexamic acid again for postpartum. As we said, it is continuing from antenatal, from intrapartum till postpartum. It is everywhere. Tranexamic acid is everywhere. If thromboprophylaxis is indicated, may be given in patient with adequate correction of 1 milligram riscotessin and factor 8 level. If the factor level is corrected, it can be given. When pharmacological thromboprophylaxis is contraindicated, mechanical methods can be employed. Then here now, we are seeing this combined pills is useful for those with postpartum period of hormonal reduction and bleeding. Okay, see now, initially I said in one slide, in postpartum, whenever we see there, I said if any point just 1 minute. What happened? What you were checking? Okay, no problem. Thank you.
I don't think this function will.
Okay, thank you. So there I said if some point I'm missing, someone can write in chat. Sorry, I'm not seeing any chat here. Now, the thing is, whenever we consider postpartum things, as we said initially, we considered bleeding. We talked about antibiotic if needed. Generally in any case, about bleeding, about antibiotic, about thromboprophylaxis, about breastfeeding, about baby, any medicine if the mother was taking, if that medicine is safe with breastfeeding, to be continued, not to be continued. There is another important point is contraception. So here, what is the benefit of this combined pills? Because it reduces bleeding. And it increases also von Willebrand production. How is that mechanism? That I'm sorry, I'm not aware of it. We have to find it out. Then it can be used postpartum if not breastfeeding, with or without tranexamic acid. Don't go this 121. This is sorry, some number in between by mistake. So combined pills for contraception in postnatal period, as long as the mother is not breastfeeding, it is a good option. Why it is a good option? You see, many cases, many conditions, it is not an option there for combined pills. You know, many cases what we read in maternal medicine. 1 minute, Baba. So everywhere we are seeing most of the cases where we don't usually recommend combined pills, but here it is a good option. So we can think like this, a little different condition. Why? Because it will control bleeding and it will help in increasing von Willebrand factor. Now, who will tell me if it will be started? Big patient is not breastfeeding, and if it can be started from which day it can be started?
Day 21.
Day 21. There will be module. I don't know when it will come, but it is there. Again, one huge syllabus of contraception. Now we came anything.
If patient is not breastfeeding, then we can start COCs in third postpartum
Sorry.
after 21 days. If
Yeah,
patient
yeah,
is
yeah.
not breastfeeding,
Yes.
we can start COC in after 21 days.
Yes. You want to ask that, or you are telling that, my dear?
I want to ask.
Yes, it is 21 days. But suppose if I'm confused with that, anyone can share. It is 21 days or 28 days.
Yes,
It's
list of
21 days.
It is 21 days because, just give me 1 minute, please. Huh?
Okay, thank you.
1 minute, please. Please, you can continue with. I will sit there. Sorry, sorry, dear. Disturbing our family also. My daughter now, she started in between children. No, they need attention when we sit. You see, because after the delivery, after normal delivery, what is the time from where after normal delivery conception will start? If
Oh,
what is the time from which day ovulation will start and conception can occur? Sorry, we are going away from our topic, but just for our general information. From which day ovulation and can happen and pregnancy can occur?
21 days.
21
whether
days.
breastfeeding or not, it depends.
Yeah, no, we are talking without breastfeeding. Without breastfeeding. Suppose if we
Yeah,
are,
21 days.
yeah, 21. So that's why this option, this combined pills can be started. I'm sorry, where did I reach? Sorry, my dear. Huh? Desmopressin. Okay. So it can be started from 21 days. Now here, as we said that it helps in controlling the bleeding. We all know that combined pills, and it helps in raising factor level as well. And it can be given with or without tranexamic acid. Now, what is neonatal management? A plan for diagnostic testing of neonate following delivery, including cord blood sampling, should be included in maternal pregnancy management plan. What plan we wrote earlier? Plan of delivery, mode of delivery, timing of planned cesarean section, which is 39 weeks. If patient presents earlier, anesthesia plan was there. With all that plan, baby's cord blood sampling plan also should be there. Cord blood sample for von Willebrand factor activity should be taken for babies at risk of type 2 and type 3. For neonates at risk of type 2 or 3, vitamin K should be given orally, that we know that, unless the factor activity is shown to be normal. And neonates with type 3 von Willebrand disease should be considered for routine cranial imaging prior to discharge and for short-term prophylaxis. Prophylaxis with factor concentrate if there has been significant potential trauma at delivery. This is, I don't know we will be able to finish this or not, because this factor 11 deficiency, just I have made few slides. Can I go through it quickly? Because it is getting late also there, wherever in India and Pakistan both. Okay, quickly I will go through it. I am not very sure how far this is, this now factor 11, because you see what I know, that our hemophilia A, B and von Willebrand is the main, very, very important. This quickly we can go through it. Factor 11 deficiency is an uncommon autosomal disorder which has both recessive and dominant inheritance pattern. Then the incidence in non-Jewish population is 1 in whatever the figure. It is common in Ashkenazi Jews with heterozygosity in 8% and homozygosity. Okay, so here, suppose if they give, till now in anything we did not read this Ashkenazi Jews, we did not read. So if anything comes like that, you know, like they will mention African, if there is any African, and if she is coming with bleeding and this and that, so our brain will go where? First thing,
Sickle cell disease.
Sickle cell, excellent. So like this, if they are giving something, if something they will give with very polished disease, they will give this their own population, no? White population, like that, very polished disease. If something little bit like that, low level of diseases and all, there will be all these other populations will be there, like that. So here, if somewhere it comes with Ashkenazi Jews, and also we should know that is factor 11 deficiency. And that time we will remember that in Dr. Fehmida's lecture, we did not hear the details about it. So why it came. So it is what it is glycoprotein that play a role in amplification of coagulation process after initial production of thrombin. So it is somewhere related to thrombin. Spontaneous bleeding is rare, even with very low factor 11 level. However, these patients are often at risk of bleeding following surgery trauma, especially when the site is rich in fibrinolytic activities such as oral and nasal mucosa and genitourinary system. So what is the specificity with this deficiency? The sites which are rich in fibrinolytic activity, bleeding will be more. That is oral, nasal mucosa and our GI system. Heterozygotes have mild or moderate reduction in factor 11 and all. That is not very necessary to read now. What are the risks in pregnancy to mother and baby? Factor 11 does not usually increase during pregnancy. Which factor increase in pregnancy?
Factor 8.
Thank you. However, levels should be checked at booking in the third trimester and prior to invasive procedure. Same as we said earlier. Women with factor 11 deficiency may suffer excessive bleeding after miscarriage or termination, especially if they have bleeding phenotype. Sorry, I'm going fast through this because we have still little more to go. There is increased risk of PPH in factor 11 deficient women, which is highest in those with a bleeding phenotype and blood group O, and least in non-O blood group. So this is another specific point with this factor 11. What we saw earlier, it is in Ashkenazi Jews, common in them, more common in them. Then we found the bleeding from the mucosal area where the high fibrinolytic activity, which is what we said, our nasal, genitourinary, mucosal areas. That is second point with this. Then mostly with bleeding phenotype, blood group O. This is another factor with factor 11. Okay, then patient with factor 11 deficiency should be assessed for the presence of other potentially compounding factors such as any von Willebrand or any platelet dysfunction, and no special precaution for the baby are required for delivery unless the neonate is at risk of homozygosity or compound heterozygosity. What are therapeutic options? Treatment option includes, say, this tranexamic acid is our friend now because everywhere we included it. Then factor 11 concentrate and fresh frozen plasma because it works with thrombin. We said no, it works for thrombin. So fresh frozen plasma. However, women with non-bleeding phenotype or unknown status can often be managed expectantly. Tranexamic acid should not be given simultaneously with prophylactic factor 11 concentrate as this is considered to increase the thrombotic risk. We are dealing with thrombin, so more thrombotic risk. So should not be given together with factor 11 and tranexamic acid. Both together should not be given. For many women, it is likely that tranexamic acid alone will be sufficient to prevent PPH. If FFP is given to raise factor 11 levels, solvent detergent FFP should be used. This we will read again in our, PPH and APH guideline where we will read about transfusion. Then recombinant factor 7A is not licensed for this condition and is generally not recommended except if there is an inhibitor to factor 11. Khalas, no need to go in that much detail. What are antenatal, intrapartum and postpartum management? Factor 11 or tranexamic acid is not usually required antenatally unless invasive procedure is undertaken or if there is bleeding following miscarriage or surgical procedure. Okay, same like if it is needed to be given, if not, usually not needed. Delivery plan need to be individualized. Prophylactic factor 11 replacement should be considered if homozygous and all this we have said. Central neuraxial anesthesia should not be given to women with low factor 9 levels with a known bleeding phenotype, where phenotype is not clear or there is severe reduction in level. Rare bleeding disorder. Before going to this, I have collected some SBAs from StratTalk. We will go through it because I think if time is short, quiz time. Okay. Anyone can volunteer, please? Anyone can read also, so everyone will hear that.
Her mother was carrier and so she has 1 in 2 chance of being carrier, depending upon which of her mother's X chromosome she is inherited?
Excellent. So
Read
our
from
answer
the
is,
start.
read from the start. Yeah, whole thing, please.
A woman is getting married and comes to you for counseling. She has a brother with hemophilia A. Her mother father is also had a disease. She wants to know the probability of her being carrier of disease and the probability of that she will pass to the disease to her children. What is your advice? Her mother was the carrier, and so she had a 1 in 2 chance of being carrier, depending upon which of her mother's X chromosome she is inherited.
True. So
True.
this is clear for everyone.
Yes.
Yes.
Clear. Okay. Because this is, as we know, X-linked, recessive, female, she will be getting 1X from her mother. Which one she has got, we don't know that. So depending on that, there is 1 in 2 possibility. Either she got the carrier one, either she did not get. So 1 in 2 possibilities there, she is a carrier. Based on the same scenario now, anyone can volunteer, please.
If she is carrier, she will pass the affected X chromosome to her son 25% of the time. This is false.
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 50%.
50%.
False.
1 in 2 possibilities there. It will go. Okay.
50%.
Okay. Now,
False. False.
everyone agree with that answer?
Yeah, okay.
True.
Just 1 minute, huh? Okay, suppose here, if it...
Hello?
Okay. What was here? Daughter will never be affected by hemophilia because they will always get a normal X chromosome from their father. Unless, yes, true. Unless in very, very rare cases where, this is true here, answer is true, but very rare cases where father also is affected. Yeah, as I said earlier, that I have collected whatever the percentages I could find in that guideline, I have collected here, percentages, levels and all, to make it little simpler form. So quickly, normal range for factor 8 and factor 9 outside of pregnancy. What is the normal range? Sorry. What is the normal range of factor outside pregnancy? It was there on that slide.
0.5 to 2.
0.5 to point. So outside pregnancy, this is 0.5 to 2. Then if a female is carrier, each son has 50% chance of inheriting hemophilia. Each daughter has 50% chance of being a hemophilia carrier. Up to 50% hemophilia cases has, anyone can read this, please. Anyone can read. Wherever you don't understand, please, I will clarify. Anyone can read this?
The normal range of factor 8 and factor 9 outside the pregnancy is 0.5 to 2 international unit per ml. If the female is carrier, each son has a 50% chance of inherited hemophilia. Each daughter has a 50% chance of being hemophilia carrier. Up to 50% of hemophilia cases have no previous family history, either owing to lack of male relatives or spontaneous mutation. 40 to 50% of cases of severe hemophilia. Development of
for one, that up to 50%, it will be like newly formed. There is no previous family history will be there. So it will be either there will be no male relatives to. Why this point is what does this point is indicating? Owing to lack of male relatives, why this point? What this point is indicating?
Female carriers will not manifest.
Sorry.
The female will be the carrier, and if there is no male, suppose she doesn't have a brother with the disease.
Yeah, excellent. Unless the male members are there, we will not know that they are diseased, and then the genetic genetically will not be known only, and suddenly you may find that the baby was born and baby was. So this can happen in 50% of cases. There is no previous family history, and spontaneous mutation also it can happen in 40 to 50% of the cases. Spontaneous mutation can happen of this severe hemophilia. Okay, dear? Yes, please continue.
Development of antibodies to the clotting factor preparation used for the treatment. This occurs around 10 to 40% of treated patients. In the general population, the risk of ISCH intracranial hemorrhages is 0.058% and extracranial hemorrhages 0.469%. In baby affected with hemophilia, ICH 2.5 and ECH 3.7%.
3.7. The percentage, the risk factor is very, very high. If we see general population, it is very less, 0.05. It will go where? 5 in 100,000. 0.1 is 1,000. 0.1 is, so it equals 10,000. 5 in 10,000. The risk is very, very low, and it becomes very high in affected. ICH intracranial hemorrhage is 2.5%, extracranial is 3.7% compared to general population. Just these figures I wrote because maybe if rare possibility any question comes, just anytime you have time in between, try to have a look at these figures. Yes, please. Sorry to stop you, my dear.
VWD has significantly increased risk of bleeding. Antepartum hemorrhage is increased tenfold. Primary PPH occurs in 15 to 30% of women, while secondary PPH occurs in approximately 25%. The need for blood transfusion is increased fivefold, and mortality rate is increased tenfold compared with a woman without VWD.
Yes, so this is very important figures here of von Willebrand disease. As we know already, high risk for antepartum hemorrhage and postpartum hemorrhage. So what is antepartum hemorrhage risk? It is tenfold, increased tenfold. And primary postpartum hemorrhage, 15 to 30%. What is the general population postpartum hemorrhage percentage? What is generally PPH?
1 in 200.
4%.
1 in 200.
4%.
4%.
4%. 4%. 1 in 200 figure you will find in many places, not for PPH now, for now, but it is there in many places, 1 in 200. So write it down, 1 in 200 somewhere else, because many places it will come. If you see VBAC scar rupture, it is 1 in 200. If you see, God forbid, IUFD, it is 1 in 200. Many times we see in our future things, we will, whenever you will read the guideline, you will find that figure, 1 in 200 in many places it is. So for PPH, as generally we said, it is 4%. In von Willebrand, primary PPH 15 to 30%, secondary PPH approximately 25%, so high risk. Then blood transfusion need also, it increased fivefold, and mortality rate also is tenfold compared to non-von Willebrand disease, without any von Willebrand disease. Then normal cases, secondary PPH is less than 1%. Here, how much? 15 to 30%. See, very big difference. Sorry, 25%. Secondary PPH, 25%. And normally it is less than 1%. Then von Willebrand disease, it is much more common. As we said, 20 to 25%. Average time of presentation with PPH in women with von Willebrand disease is 10 to 20 days after delivery. So as they said that all these people, they are supposed to liaise, they are supposed to be registered in hemophilia center, and they will follow up there in hemophilia center. And prolonged, this tranexamic acid is given for longer duration also in these cases. Then factor 11 deficiency, risk of PPH increase in blood group O, that we said already, nearly how much it increased? Fivefold compared to non-O blood group. Factor 11, what points we have seen in factor 11? It is there in Ashkenazi Jews. It is specific to blood group O compared to non-O blood group. The bleeding is more where the fibrinolytic activity is more, which is mucosal areas, nasal mucosa, and genitourinary things. No, these points what we have seen. Then non-O blood group and non-bleeding phenotype. This is the percentages. This I have copied from same our GTG. Whichever GTG and TOG, you will see this type of charts. Please memorize it, print it out, put it in your folder wherever you write the points or wherever it is, because usually question comes from there. And whatever points given in those charts and all, please go through those thoroughly. Has to be thorough with those points. Many flow charts and all are also there in many guidelines, so you have to be thorough with that. So now they have, like, this is just categorization. Whatever we have read earlier, they have simplified it. Actually, I had I unfortunately, because of my busy schedule and all, due to this corona everywhere and these duties are changing and all, I could not do it. But whatever we have gone through, factor 8, factor 9 and von Willebrand, all these three, maternal risk, factor level, fetal risk, factor level and management, this small points, if anyone can do it. If not, I will like a chart, like a column of all these three things: antepartum, intrapartum, postnatal, baby, factor level, where desmopressin can be given, where desmopressin cannot be given. We will not give in B, hemophilia B, factor 9. We will not give in type 2B, von Willebrand, because it will cause thrombocytopenia. Factor 9, hemophilia B, it will not respond. Desmopressin cannot be given. What all the factors and all that, if it is one paper, it will be easy for you guys for last minute revision. Now, our two TOG, as our group promise, unfortunately, I am sorry, but I don't think now there is time to go through it. One is already there, this iron deficiency anemia, but I don't want to rush hurriedly with that. It is there, the whole thing is there, because in TOG and all, what you will do, whichever TOG when you read, again, as I said, important to go through charts. And in between, if small things, if you have, which can become additional factor along if some GTG is there, like that. But charts are very important, because for TOG, especially many question comes from TOG. As we said earlier, last 3 years, better 5 years, and some important TOGs, which is like always very favorite TOG for this RCOG, and mostly question comes from there. So one of them is thrombocytopenia, one of them is iron deficiency anemia, asthma, there your SLE, myocardial infarction. Like this, some important talks are there where every time you will find, and throughout our this whatever we are continuing, inshallah biiznillah, we will try our best to cover maximum whatever we can cover. And again, I will before we will conclude, and anyone will have any question to ask and all, I will, these my two is like I will try my best to cover in my upcoming lectures, or I will arrange one extra slot. I will request Dr. Hira and Dr. Takwa to arrange one extra slot as my promise to complete these two TOG articles for you guys. One is iron deficiency anemia, another one is thrombocytopenia. There was little more part of there also for this presentation. There was this Glanzmann's thrombocythemia, and our one more is there, Bernard-Souvier syndrome. So if you people still have some capacity to absorb, our new thing was rare bleeding disorder. We will say where we feel any important point, we will stress on it. Otherwise, we will try to go through, not very quickly, but in average way. So rare bleeding disorders include what all inherited, all the clotting things are here, whatever the clotting factors in our, as we said, our coagulation pathway, fibrinogen, factor 2, 5, 7, 10, 11, 13, combined factor 5, factor 8, all. And congenital deficiency of vitamin K dependent factors. 3 to 5% of all inherited coagulation deficiencies. These disorders are 3 to 5% of all. What was the percentage for our this one, von Willebrand? What was the percent?
1%.
1%. Thank you. Now, genetic counseling should be provided with understanding that most rare inherited bleeding disorders are autosomal recessive in inheritance, and heterozygote carriers are usually asymptomatic. So, mostly they are autosomal recessive. That's why, alhamdulillah, not like everyone is suffering with all these bleeding disorders. And for affected women or asymptomatic heterozygous carriers, consanguinity should be established to allow counseling, screening, and when possible, formulation of a delivery plan for potentially affected baby. This is a general theme, what we said for all our other things, genetic counseling, assessment, and maternal and paternal status. Then coagulation factor level can change during pregnancy, that we know already. Management should take into account both factor level and whether there is clinical history. Important, as we said earlier also, factor level should be, what is that, to be find out for all the cases, and if any historical bleeding history is there. Factor replacement therapy is usually advised for delivery in women with severe coagulation factor deficiency or if any bleeding history. This is general consensus. Then tranexamic acid at a dose of 15 to 20 milligram per kg or 1 gram 4 times daily. 4 times. You remember we said earlier whether it is what we were talking? It will be how frequently, either remember in hours, every 6 hourly, or remember 4 times per day. It is not 4 to 6 hours. If we calculate 4 to 6 hours, it will become 6 doses. It will become 6 doses, isn't it? So our tranexamic acid in other cases also, if you go through the guideline, in other cases wherever we read tranexamic acid, the dose is 15 to 20 milligram per kg or 1 gram, and it is 4 times daily. Then can be used for minor bleeds and in combination with factor replacement, same as we said earlier. If the baby is at risk of severe deficiency, delivery plan should include avoidance of ventouse, mid-cavity forceps, scalp electrode, and scalp fetal blood sampling. Then central neuraxial anesthesia, postpartum pharmacological thromboprophylaxis, and NSAIDs should usually be avoided in women with severe deficiencies. Overall, same as we have read earlier. Now, small points about whatever important factors. Factor 2, which is prothrombin. If factor 2 activity is less than 0.2, there is significant bleeding, established labor or prior to cesarean section, give prothrombin complex concentrate 20 to 40 units per kg to achieve factor level 0.2 to 0.4. So here we came with some different figure. Till now, our figure was 0.5 to 1 to maintain above 0.5. If we treat to maintain up to 1 international unit per ml, that was our for hemophilia A, for B, for 1 millibrand. But when we reach to prothrombin, the level is 0.2 to 0.4. Okay? Little different figure here. Consider further prothrombin complex concentrate 10 to 20 at 48 hours interval to maintain factor level more than 0.2 for at least 3 days. So, I don't know about the dose, if it is that much important or what, but it should be maintained further for 3 days once we start treatment, either post-delivery, during labor, or postnatal. Then women already receiving prophylactic prothrombin complex concentrate can continue it throughout the pregnancy. This is one new point what we found. If she's already on prothrombin factor, then she can continue it throughout the pregnancy. This is about prothrombin. We found here new figure, which is 0.2 to 0.4, and we found it another new point. If she's already taking it, she will continue it throughout the pregnancy. This is prothrombin, factor 2 deficiency, prothrombin. Okay. Now factor 5. For significant bleeding or delivery in women with factor 5 activity less than 0.2, 15 to 25 milligram of FFP should be considered once in established labor or before cesarean section to achieve factor 5 activity. Okay. Now, just for our to make it easy for us, as long as we read hemophilia, we read 1 millibrand, our factor was 0.5 to 1. Now, when we are going to rare bleeding disorder, prothrombin, factor 2, factor 5, let us keep like that. When we are coming down, with our bleeding disorder, our values also are coming little down. So from 0.5 to 1, we reach to 0.2 to 0.4, just to make it simple for us to remember. Okay. So,
okay, ma'am.
Okay, so for factor 2, factor 5, 0.2 to 0.4. In factor 2, that is prothrombin. So we are giving prothrombin concentrate. Factor 5, we are giving fresh frozen plasma. When we are giving in established labor before cesarean section to achieve level what? Level 0.2 to 0.4. Then again to be repeated 12 hours interval to maintain factor 5, 3 days. That 12 hours and that no need to go into that much detail. I am not very sure they will add that much minute point, but 3 days is important to remember, because we have in our previous discussion also, after uncomplicated normal delivery, 3 days. Cesarean and instrumental delivery, 5 days. So here also to be maintained 3 days. Where possible, solvent detergent, fresh frozen plasma should be used to reduce the infective risk. And for severe bleeding or cesarean section, consider additional platelet transfusion. So prothrombin and factor 5 level is 0.2 to 0.4. If level goes below 0.2 in prothrombin, we are giving prothrombin concentrate. In factor 5 deficiency, we are giving fresh frozen plasma. And in factor 5 deficiency, still if it goes more low, where we are giving fresh frozen plasma, we can give even additional platelet transfusion also. Just simplify for yourself so that whatever trick you can find to remember these things, you apply that trick. Whatever you feel, it is easy for you people to remember. I used to do like that, how to correlate, so it will be easy to remember. So just do like that. So any point you feel, find for yourself what you feel, it will make it easy for you people to remember. So now factor 7. For factor 7 activity, again less than 0.2 in third trimester with prior history of bleeding, consider recombinant factor 7A, 15 to 30 microgram per kg every 4 to 6 hours for at least 3 to 5 days following cesarean section. So for factor 7, we are giving factor 7. For all other women, recombinant factor 7, 15 to 30 microgram is recommended only in response to abnormal bleeding. For mild bleeding, tranexamic acid, again 4 times. So tranexamic acid, 1 gram or 15 to 20 milligram per kg, 4 times. This is everywhere. It is the same. For severe bleeding, and if you people find something else more than 4 times, you can update. No problem for that. Huh? For severe bleeding, recombinant factor 7. For severe bleeding, recombinant factor 7 can be given and repeated if required 4 to 6 hours, usually for minimum of 3 doses. Factor 7 deficiency, where 2% of the patient with a severe bleeding phenotype are heterozygous. If there is a risk of severely affected unit, full restrictions are required. So anyhow, again, the gist of all these 3 things what we read, the factor level 0.2 to 0.4. If it goes there. Yes, my. So 0.2 to 0.4. If it goes less than 0.2, then we are transfusing what we are giving in prothrombin, we are giving prothrombin concentrate. In factor 5 deficiency, we are giving FFP. If not yet controlled, we are giving platelet. In factor 7, we are giving factor 7, recombinant factor 7A. Okay, I know this is not very simple thing, but sorry, we have to again and again go through it. Okay, dear. Now, severe factor 10 deficiency. Again, for delivery in women with factor 10 activity less than 0.3 in the third trimester who have a history of bleeding and all those who require cesarean section, use prothrombin complex concentrate. Oh, consider further prothrombin complex like there. So factor 10, what they have written, prothrombin complex concentrate. Here the value is little different. It became 0.3. When we reach to factor 10, some change has come, which is 0.3. Otherwise, we were managing. We were happy with 0.2 to 0.4. But guideline says no need to be happy for long time. Some change is needed in our happiness also. So when we reach to factor 10, level became 0.3. Okay, little change. Then anything else? Antenatal prophylaxis may be considered in women with history of recurrent bleeding or adverse pregnancy outcome using prothrombin complex concentrate 2 or 3 times a week. Okay, in factor 2, what we said earlier, that in factor 2 deficiency, what we said, if the woman is already receiving prophylactically, if she is receiving prothrombin complex, she can continue throughout the pregnancy. No, that's what we said in prothrombin factor 2 deficiency. Same here also in factor 10 deficiency also, they are telling if she is with history of recurrent miscarriage, recurrent bleeding or any adverse pregnancy outcome, that can be again prothrombin complex concentrate 2 or 3 times per week. It can be maintained through factor 10 more than 0.01, something, many values are there. I'm sorry, my dear, I will not say don't read this. I will not say also that it will come or it may not come, because something very minute details. And you see, whatever we think about exam, it is not that hard also. They want us to pass, to go through it and to clear it. So I don't think that somebody will go through all this much very minute detail. So no need to mess with that much detailed figures. Then severe factor 13 deficiency is what? During pregnancy, increased intensity prophylaxis is required using factor 13 plasma concentrate or recombinant factor 13. Dosing frequency should be increased from every 28, 14 to 21. For delivery, consider additional factor 13 concentrate once in established labor or before cesarean, depending on the interval. Oh, alhamdulillah. Whatever we understood from these 3 slides, I don't know that, but at least we moved to fibrinogen. This we will see little bit. Fibrinogen disorder. What is this? Fibrinogen disorder can be autosomal recessive, that is afibrinogenemia, or autosomal dominant with quantitative or qualitative defects and are associated with variable. Okay, go. Come. So variable clinical phenotype can be seen in fibrinogen disorders. What is the characteristics of this thing? There can be poor wound healing and splenic rupture. Severe fibrinogen deficiency may be associated with bleeding, but quantitative and qualitative deficiency can also be associated with thrombosis and pregnancy loss. This we are finding now. Throughout, or what all we read, we did not find pregnancy loss there. But here we are finding where? In fibrinogen disorder. Okay. So this is one important point here. If functional fibrinogen is less than 0.5 gram per liter, consider prophylaxis throughout the pregnancy with fibrinogen concentrate initially, whatever the amount, twice per week, adjusted to maintain through 1 gram per liter. This figure, later on when we will read that PPH, APH guideline also, there is how much fibrinogen to maintain when there is bleeding. Then higher doses of fibrinogen concentrate are likely to be required to maintain fibrinogen activity as pregnancy progresses. Consider additional fibrinogen concentrate for established labor to ensure fibrinogen activity is more than 1.5 liter for at least 3 days. Tranexamic acid can be used. Okay, so here this fibrinogen figure, same figure when you read our APH, PPH guideline also, for what level to be maintained fibrinogen, that is there. Only the thing is here, there is a heightened risk. This is associated with thrombosis and pregnancy loss, fibrinogen disorders. Fibrinogen replacement therapy is associated with high risk of thrombosis and require vigilance. You see now, there is 2 things. This deficiency itself is associated with thrombosis and pregnancy loss, but if we are replacing, again high risk of thrombosis and requires vigilance, means both. You know the way we tell the thief to run and we say police to catch, like that here. That policy applies here. Deficiency we can cause also thrombosis. When we replace also, there is risk of thrombosis. So means high vigilance is needed. Now pregnant women with thrombotic phenotype or other risk factor for venous thrombosis and with a low risk of bleeding should be considered for thromboprophylaxis with low molecular weight heparin. This is one new point here. We never read in our other things, but here thromboprophylaxis is there. Then Central neuraxial anesthesia, NSAIDs and intramuscular induction should generally be avoided. We know that all bleeding disorder, this is common general consensus. Then use of mid-cavity forceps, rotational forceps, ventouse, fetal blood sampling, scalp electro should be avoided in baby at risk of fibrinogen deficiency associated with bleeding phenotype, and severe fibrinogen deficiency is associated with risk of neonatal intracranial hemorrhage. So let us go back again very quickly to this. What we said, this is autosomal recessive. Severe deficiency, it can be associated with bleeding and it can be associated with thrombosis and pregnancy loss. Okay, if women, they are already taking it, it can be continued in the pregnancy, as we said for factor 2, prothrombin. Then if deficiency, it can cause thrombosis, pregnancy loss, but if we treat, also high risk of thrombosis. Okay, and if there is risk factors for venous thrombosis but low risk of bleeding, in that case we can consider thromboprophylaxis with low molecular weight heparin. Okay, other points are same as we have seen with other all bleeding things. For mother, for baby, for forceps, ventouse, FBS, scalp electrode, and this one, risk of intracranial and extracranial hemorrhage. Okay, so far? Hello?
Yes.
Okay. Okay. I know it is not easy task. And in one go, believe me, don't think. Now, once you finish this tomorrow, if you sit, if you can remember even 20% of this, what we talked today, I will say that would be great from your side. Because this needs revision. Now, platelet function disorder, there are two things which we will see quickly. Now we will say quickly. Glasman thrombocythemia and Bernard-Soulier syndrome. Bernard-Soulier syndrome is caused by genetic abnormality of an important platelet adhesion receptor, that is glycoprotein deficiency, which causes this and is often associated with severe bleeding phenotype. It is associated with thrombocytopenia and large giant platelet are there. That is the thing with this Bernard-Soulier syndrome. Large platelet, giant platelet, and could be confused with immune thrombocytopenic purpura. It is an autosomal recessive disorder. In areas of high consanguinity, it may be prudent to test the father using platelet flow cytometry and glycoprotein surface density. It is associated with significant risk of primary and secondary PPH and wound hematoma. Wherever platelet is not aggregating, as we said, von Willebrand also, no? So there is primary and secondary PPH, wound hematoma. Management of delivery therefore requires careful planning with MDT. Patients with bleeding history should be given a platelet transfusion prophylactically at delivery or before cesarean section in combination with tranexamic acid. This is the only faithful partner which is continuing with us from the beginning till now. Imagine, as long as we are awake, tranexamic acid is with us.
Yes,
it should be given it should be given at onset of labor and continued regularly through postpartum period until lochia is normal. Wherever you see this bleeding things and lochia, put tranexamic acid there till it becomes lochia becomes normal. Desmopressin has variable. We know that it is leaving us in between. It has variable efficacy and is unlikely to be useful as a sole therapy in Bernard-Soulier syndrome. Central neuraxial anesthesia should be avoided. That we can understand very well, because where there is a problem with platelet, it should be avoided. So again, a quick review for it. It is what? It is a deficiency of glycoprotein, which causes problem with what? Problem with platelet. What platelet becomes? It becomes large and there is adherence problem with the platelet aggregation actually, which causes then bleeding. So they are more at risk of what? Primary and secondary postpartum hemorrhage and wound hematoma. Okay, so MDT management for the planning of delivery. Then we can give what? We can give platelet transfusion either prophylactically at delivery and before cesarean section, together with what? Together with our friend tranexamic acid. Desmopressin will not be very helpful, so cannot be given as a sole therapy. Central neuraxial anesthesia, we know platelet problem, so should be avoided without any second thought. Then our little is remaining now. Glanzman's thrombosthenia. This is again platelet problem also, that platelet function with autosomal recessive inheritance is often associated with severe bleeding tendency. Platelet aggregation is impaired with defective primary hemostasis and clinical presentation in early childhood. It is associated with significant risk of intrapartum and postpartum hemorrhage and a careful plan of management, as we said, for delivery. Then platelet transfusion or recombinant factor 7A should be given prophylactically. There in Bernard-Soulier, what we said, only platelet. Here they said even factor 7 also should be given at prophylactically should be given at delivery for patient with history of bleeding. Repeat doses may be required depending on the picture. Desmopressin has not been shown any effective thing in Glanzmann thrombosthenia. Tranexamic acid should be given from the onset of established labor, continued regularly, and through the postpartum until lochia is normal. Everywhere, tranexamic acid until lochia is normal. Central neuraxial anesthesia should be avoided. So you see, now you people will think both is platelet problem. Both has glycoprotein deficiency. The number only, the glycoprotein number is different. One is 1B and one is something else. Now here, the in what both has bleeding tendency, both problem with aggregation of platelet. The differentiating point in Bernard-Soulier syndrome, there are giant platelets. Because if the scenario comes, it will be really confusing there. So it is with large platelets, giant platelets. If someone else finds some other differentiating factor, please post it in chat or in group. Okay. So this is both with a problem with your platelet, but this Bernard-Soulier with giant platelet. And what we are treating it with our tranexamic acid in both the things. Desmopressin will not help here. It will not help there. Here we are treating with platelet. There with platelet in Glanzmann's we can give even recombinant factor 7A also we can give. In both the cases, APH, PPH, intrapartum, postpartum hemorrhage is high risk, and tranexamic acid to be continued until lochia becomes normal in both the cases, because this is platelet problem. Central neuraxial anesthesia should be avoided. Then recombinant factor 7A is licensed for use in patient with Glanzmann thrombosthenia who has antibodies to whatever the factor name and with past or present refractoriness to platelet transfusion. The recommended dose is 90 microgram and intravenous injection every 2 hours. At least 3 doses should be administered to secure hemostasis in patient with active bleeding. Maternal alloimmunization to paternally derived fetal platelet antigens may cause fetal thrombocytopenia and risk of intracranial hemorrhage and other fetal bleeding is there. That we can understand this, as we know in ITP. The same factor here, baby also can be at risk of thrombocytopenia and risk of intracranial hemorrhage. If feto-maternal alloimmunization does not occur, there is no need to restrict aids to delivery. Women should be monitored for platelet-specific antibodies at booking, at 28 weeks, and at 34 weeks. This is additional point now. If feto-maternal alloimmunization occurs, management should involve a fetal medicine unit with experience of these conditions and treatment with intravenous immunoglobulin with or without. This is all in somewhere we will come along with that ITP in any of our topic. It will be there, ITP. So these points are very much relevant to that. Wherever there is idiopathic thrombocytopenic thrombocytopenia, in that case, there is definitely feto-maternal medicine management, and there whatever together with the platelet and all, or to this immunoglobulins, intravenous immunoglobulins is being given with or without steroids. Then amniocentesis with platelet typing may be considered in cases of paternal hit. This is all our genetic thing. Then if baby is at risk of homozygous Glanzmann thrombosthenia or feto-maternal alloimmune thrombocytopenia, restrictions to delivery should be applied as for babies. Whatever point we consider there, like no mid-cavity forceps, no ventouse, no FBS, no FSC, all these points will be applied there. This includes, as we said, avoidance of ventouse and all these things. elective cesarean. Depending on the risk, elective cesarean section may be considered. Considering maternal risk together, definitely we have to see. So elective cesarean can be considered there. Neonatal care of potential alloimmunization requires a cord platelet count and withholding intramuscular vitamin K until the result is known or administering it orally. Platelet count below the normal range should be repeated at day 3 to day 5 when the platelet nadir is reached due to development of neonatal spleen. This is again the point here. For baby, that time we will do at birth. Again, it will be repeated day 3 to day 5. Platelet transfusion should be given if the platelet count is less than 30. Sorry, this 3 by mistake. Somewhere, if it is less than 30. 10⁹ per liter. Okay, so very quick review again. Both these conditions is platelet aggregation disorder due to deficiency of glycoprotein, which interferes with platelet adherence. Okay, in Bernard-Soulier, we can give
I have
this. Yes,
I
my
have,
dear.
I'm not very sure about that, but I think from my previous memory, I think one was adhesion disorder and one is aggregation disorder.
Yeah, exactly. Exactly. But both in the end, if you come, like question if comes there, when we see in exam, suppose if that point is not very clear, because sometimes if we sit, generally if we sit and think, because I read not only this guideline, to get along one strong differentiating point. Suppose if the question comes in exam, I opened that NHS article also, I opened some CDC article also to find some strong differentiating point with exam point of view. What you said, that point is very correct, adhesion and aggregation thing. But sometimes, like in our vague memory, if we go in exam stress, suddenly we may not remember these two things exactly there. So what the main differentiating point, what I found, that is good point what you said, of course that will be there, but this giant platelets I found in Bernard-Soulier syndrome is written every, and that giant platelet is not there in Glanzmann thrombocythemia. So good point what you added there. If that point also, if we remember, it will be good. Here we have written already adhesion.
Okay,
Receptor abnormality in adhesion receptor, that is good point. And here in
PG entrance time, when we used to study for PG entrance time, no, this was an MCQ, it seems. One is
excellent, very good, very good. In our both the slides it is there. Here platelet adhesions receptor interference, and here aggregation is impaired. Okay, my dear, that is good point what you highlighted. It is there, but what the giant thing what I was telling, this is just for our, like to say gross classification to remember there. That's what I, because I read 2-3 articles, I read to something important point. If it comes there, if it comes aggregation and adhesion, that is very good thing, easy, we know that. But with exam stress, believe me, and you have gone through entrance PG exam, so you can know it. With that exam stress, sometimes this small points we don't remember there very well. So I thought this giant thing to stress more. Okay, my dear?
Yes, ma'am. Yes, ma'am.
So we were on again on giant part, and then our treatment thing, tranexamic acid, in both the things it is there. Desmopressin, it doesn't help, as we said. What I was going to repeat again here was in Glanzmann thrombocythemia with platelet, we can give even recombinant factor 7A also. It can be given where it is bleeding phenotype. It can be repeated also. Central neuraxial anesthesia we mentioned already. Okay, restriction to delivery. If there is no feto-maternal alloimmunization, there is no restriction to delivery. But if it has occurred, then all our points, what we consider in all the other conditions, that is for CEPs, VEN2s and all, that we said already. And wherever there is alloimmunization has already occurred, then we will monitor for platelet specific antibodies. Where we will do that we will do at booking at 28 weeks and 34 weeks. And treatment part, there is same like what we said in what is that ITP, that is our steroids and immunoglobulin. Then what else is there? Platelet transfusion should be given if platelet is less than 30. Should be repeated for babies again at 3 to 5 days because neonatal spleen will develop at that time. This is additional point here. Now, again, I think only one slide is there. Management of women with inherited. Now, until now, we said the details of all our delivery thing, intrapartum and all. Now, when there is termination of pregnancy. So little, I think some ethical point is also there, or I included, not included, I don't know. Women who have disorders with a medium or high bleeding risk, they require MDT in a unit with 24-hour access to blood products, factor replacement, and specialist hematological advice. Factor level should be measured in hemophilia carrier, women with von Willebrand and women with known factor deficiency, whatever factor we read till now, prior to any medical or surgical termination. That we said in our earlier presentation. Factor level should be corrected to those indicated for labor with the treatment outlined above and maintained for 24 hours post-procedure. Bleeding post-procedure should be closely observed as an inpatient, and similar treatment outline for postnatal management should be employed, whatever we said in our normal delivery part. In the days and weeks following the procedure, open access to gynecological units and hemophilia center must be arranged as the risk of bleeding can continue for several weeks. Almost it is the same only some additional thing I found highlighted with in our GTG, so I added here. We have gone through this already. Statistics we have seen, statistics. This chart is already there. You can review from. In fact, more simpler, we can prepare by ourselves according to what we understand. It will be what we write, it is easy for us to understand. So we can make for all the three things, especially for the three things, our von Willebrand, hemophilia A and B, with all specific factors, whatever you feel, write down and write the categorization. What can be given, what cannot be given in one page. This is our talk, which I believe, hopefully, inshallah, we will do in our future presentation. 2 talks already. I promise that I will do thrombocytopenia and iron deficiency anemia. Any doubt so far? There will be many doubts now with this guideline. Thank you so much, my dear. Actually, this is the thing which we don't practice daily, and especially our practice is not UK-based practice for most of us. I am also working here in Saudi Arabia. Actually, in our hospital, most of our consultants are all MRCOG only. So most of our practice is like based on our guidelines only. Most of our policies are based on guidelines. So that's why these things becomes little difficult for us. Plus this one is, which is not very practical topic. So this becomes little more difficult to grasp, to absorb it. But exam point of view, when certain thing which we cannot avoid, means we have to do it. Now we cannot go for exam without reading this guideline at least minimum once. So we have no other option rather than going through it. So do it by heart. Think it, no, I have to do it and I can do it. So definitely anyone can do it. When I can do, others, whoever MRCOG. So means it is not like, no, you people cannot do it. Only dedication, hard work is the key for this exam. Whatever you read by heart, make your small notes, write percentages somewhere, similar percentages. As I said, 1 in 200 you will find in many places. Write it down, make your own one small booklet where you will write all the percentages, where you will write one folder where you will make all these flow charts and all GTGs where you find, you will collect there and all. Last minute, these things are very, very helpful, my dear, because we have to find our own ways to get through this exam in one go, inshallah. And MedHome is a platform which is trying its best to give the maximum chance for you guys to achieve your dream. Inshallah.
Inshallah.
Inshallah. Thank
Okay,
you,
my dear.
Dr. Fehmida. Thank you, Dr. Fehmida.
Thank you, thank you, thank you. So, inshallah, Dr. Hira will update about our next lecture. I think it is day after tomorrow. And see you there.
Ma'am, regarding this topic, can be uploaded as PDF?
I will request Dr. Hira in, I will sure. I will request Dr. Hira in whatever way she will make it as easy as possible for you people, even in either the PDF, either as a PowerPoint, and definitely lecture, as she said just now. I saw her chart, then she said that lecture also, this our thing also, meeting, whatever she has recorded, she will post it, and this in whatever form it is easy, she will do it. Don't worry, inshallah. Inshallah. Dr. Hira is the, what I will say, there are very few people you will find in this world, those who like without any to help the people more than what we think. So she is like one of that kind of person. May Allah bless her, may God bless her, and whatever together with her, whatever we are trying our best to help you guys, hopefully in some or the other way, it will be somewhere in your life, you will get some benefit through it, inshallah.
Inshallah.
Okay then, anything else before we will conclude and say bye-bye to our inheriting bleeding disorder for now?